Hey guys, Don here. Welcome to the $1 Million Minute, where we're helping you bring your practice to the $1 million mark and beyond. We were in the third day of our ModMed training. Today we went over like how to document ultrasounds. A couple of things that I'm a little kind of frustrated with. Not frustrated, but I'm used to what Athena does, and Athena makes it really easy to document X-rays and also ultrasounds. It's very easy. You just kind of click what you see in the ultrasound read, and you click that, and it just adds it to the note. In this type of thing, you have to do a little bit different. We're gonna have to figure out kind of a workaround for that. And the actual bones are hard coded, and so you can't really change things. So I'm still kind of learning about that. A few people have sent me some templates that I can kind of look at how to integrate them and how to modify them for our office when we need to make the protocol. So what we did today is we made a Google Doc and we separated, or actually a spreadsheet, one of those spreadsheets to separate it between doctors and kind of which ones we're going to make in terms of the protocols. I think making that within, I think we have a week and a half, we're going to do our actual turnover. So we're trying to figure out how we're going to set up and do these notes. Because basically, from what I remember, the last EMR we switched to, all patients for the first time we see them are going to be new patients. So even routine patients, you can't do new from old. Everyone's going to have to be a new note. So we're going to have to get pretty good at making those notes. The other thing we're trying to figure out is they're going to be transferring all the data over like a week before. And so what about all the updates that we make into people's charts? Like, for example, new patients that go in or modifications to people's emails or telephone numbers. We have to document that. So we're going to have each staff kind of document that in one location. So those are kinds of things that are going on with ModMed. Now we are in the sandbox, and we actually have our regular logins with some test patients so that we can play around and mess with these templates. So that's what we're going to be doing next. Another kind of idea I posed to my SEO person was an urgent care for feet. So I did, she looked up, and there was a website that had an urgent care for feet in Boston. I think it's an actual just a marketing website that people can buy space on, and they can get referrals, and they probably pay per referral for those types of patients. There is also, in Mass Brigham, there is a foot pain urgent care, so kind of a walk-in urgent care. So we are determining if we're going to put a link on the website for like an urgent care appointment, kind of fitting in people for same day or asking questions or things like that. So we're trying to figure out how to do that. Also, I did talk to, as I mentioned, I'm trying to get my practice rep this quarter or this next month, and we talked to one. She is studying in Connecticut, and she manages a nail salon in Connecticut, and she's Vietnamese. And so I talked to her about possibly coming and doing this project for us. So kind of excited about that. Today I'm recording on a Wednesday, the day of patients from Wednesday, since we had training until about 9 a.m. With ModMed, and now then I saw patients. So I had 19 patients, 0 openings. So first patient was, and also I didn't have Morali today, so just a kind of a feedback. I did okay without Morali. I did all my notes on my own, like a big boy. It worked okay. Only the ones that really made me tired were some of the more complex ones with documenting like X-rays and a lot of these complicated procedures. But for the most part, it went well. So the first patient was a Lamisil follow-up. So she was a Lamisil follow-up. Didn't really see much improvement, so then I switched her over to Dlucan. So I switched her from Lamisil. If I don't see improvement after 3 months, then I switch to something else. Next patient was she was a post-injection patient. She was doing much better, and she was also my orthotic patient. So based on the injection where she had it, it was kind of in the navicular cuneiform region. Felt much better, but I think there is some arthritis in there, so I recommended an orthotic to not further overwork those joints. The next patient was a new patient. He had injury to his big toenail, had thickening of the nail. I debrided that nail, took a nail sample. I'm going to see him back in 3 weeks. So it's possibly either nail fungus or it's just from trauma. So we're going to make sure before I put him on anything whether it's a fungus or not. The next patient was the first post-op for the sesamoidectomy, tibial sesamoidectomy. She's doing much better. I took the X-rays, and I'm going to see her back in 4 weeks. Transitioned her to a walking boot. Next patient was EPAT number 2 out of 6. Oh, about my surgical patients, I tend to give them a surgical shoe in the OR, and then when they come in, I switch them to a post-op boot, cam boot, mostly because of billing, because I can bill their insurance for the cam boot, and I don't need the post-op shoe. Next patient was a number 5 of 6. This is a guy that's going to do that like 50 or 150 mile hike. He's doing much better. I'm noticing a noticeable change after 5 weeks on his posterior tibial tendon. So one nice thing about doing 6 shockwaves is by the 5th or 6th, you're really seeing the anatomy change, and it's nice to be there when they see that big change. And this is what Paul told me, who's my shockwave coach. He said, Don, it's nice to be there when they go around that corner and they start to feel really good, because you kind of get the credit. What used to happen is I used to do 3, and then I sent them over to physical therapy, and I feel like physical therapy always got the credit, not me. So he's happy. Next patient was she's a shockwave follow-up. So she had 6 sessions of shockwave. She did 3 6-week follow-up, then another 3. She's feeling much better. But she's still having a little bit of discomfort. I just told her it can take a little bit longer, so I'm going to see her back in 6 weeks. I did get bilateral x-rays because she was concerned about her bunion, and we talked in detail about her bunion. But I really think she's going to do better with an anatomic shoe versus the bunionectomy. Then I did have 1 cancellation that didn't show up. This was a new patient with some left foot pain. And then another first post-op, she got a cam boot, x-rays, and I'm going to see her back in 4 weeks. She had a bunionectomy and an arthroplasty. She's doing much better. She had a little chronic pain and fibromyalgia, and she initially was in quite a bit of pain, but now she's doing much better. Because of that, I'm going to send her to physical therapy. I don't send a lot of my patients with bunions to physical therapy, but I really want to keep that joint moving and everything kind of moving on her foot. So that was the morning. During my lunchtime, I did talk to someone from Medics, because they were unfortunately probably a little perturbed that we decided not to get another focus shockwave, and we went to SoftWave. So kind of, I think, as doctors, I'm kind of happy to have 2 different devices so I can try the 2. So I have 2 radial devices. I have a SoftWave in one office and a focused in the other. And, according to them, they're like, oh, you shouldn't be mixing them. But really for patients where they want to make the appointment, I'm using both really the same way. And I will tell you if I see any big difference. But for now, I see about the same with both of the machines. But reps never like that. But I did start to go through some of the SoftWave training. They do have a lot of good marketing. I feel I think that even that's the good thing as a marketing person, that I like marketing. But the bad thing, I think the critique I hear is they're quite a bit more expensive than the other machines. But if you think about it, I'm just thinking out loud here. Usually with Medics, you need 2 devices. You need the radial and the focused. I'm thinking the idea behind SoftWave, you wouldn't need both. You just need 1, and that's maybe why it's more expensive. I'm guessing maybe that's their rationale for how they can charge an exorbitant more amount for their device, unless it's that much of a better device. But really, the focused Medics device or focused Storz device really just seems more of a quality device in my opinion. Like I said, if I only had 1, I would have the Storz, but it's nice to have the other one just to try it out. Okay, afternoon, EPAT number 3 out of 6 for this patient, plantar fascial pain. Next patient was a new patient. He had lesions on the 4th toe and the 4th med head. He thought they were warts, but they were really porokeratomas, so I did lesion destruction on those. An office visit, he'll be back as needed. Next was a patient. He had follow-up with possible shockwave. We did not end up doing shockwave for him. He was doing better, but we are going to send him for an MRI because things weren't getting better in his foot, and I wanted to kind of see what was going on in there. Next was a bilateral EPAT for plantar fasciitis, and we're going to scan for orthotics the next visit. Now, one thing that I tend to do, I don't know if you do this, but there's a billing tab I can look at in Athena. And so for some of these that I know they're going to be very expensive, I just go and look. And this was one I looked today, and I was shocked. I saw, this guy, he paid $1,500, but it was bilateral. So my staff didn't see that it was bilateral when he paid. And so I had to say to them, hey, please call this patient, and they shouldn't pay $1,500. It would have been, $3,000 for bilateral feet. So that's kind of an uncomfortable conversation. Maybe I should have checked. Maybe Morali didn't write bilateral, but I don't know. I guess I'll take a responsibility because it's my clinic and my patient. So I have to fix that, or my staff has to fix that. Next patient was a patient that had a possible infected big toe. He had an injury to the toe. It kind of got pushed back. He had some pus a couple of times when it was antibiotics at the base, kind of like a retronychia. For those, when there's pus, I tend to avulse them. So I avulsed that. I called it an IND because I put a total avulsion to pull it off because of the infection that was in there. I'm going to see him back as needed if there's any problem when it grows back. The toenail grows back. Next patient was a patient that had some pain in his anterior ankle and his posterior tibial tendon. Previously, about 5 months ago, I did a cortisone injection to the ankle. He felt much better. Today, I did an ultrasound. He had some swelling around the posterior tibial tendon, so I did a little cortisone around the tendon sheath. And then I also did one into the anterior ankle, so 1.5 cc's in each of those, and he'll come back as needed. I talked also about possibly for the posterior tibial tendon doing some Shockwave, and maybe even for the ankle if this continues to come back. Next patient was a Lamisil follow-up. She has an interesting case. So I gave her 3 months of terbinafine. The nails look a little bit better at the base, but the problem is she has these ingrown toenails, and then they're lifting up, and like the soft tissue is lifting up inside of them. So this is the first time I ever did this, but I put my hand in my pants, and I just kind of explained, okay, if your nail is flat, it's attached to the nail bed like your pants. But if you pretend it's ingrown and you lift it up, there's that gap in there. So it kind of, as you pretend you're making an ingrown toenail on your pants. And I say that little gap has to be filled in. And so that's where the tissue fills in from the nail bed. And I don't have a great way of getting those nails to reattach or to come down. She had this bilateral on her hallux that caused some nail thickness, which could have become fungus. But then how do you get those darn things to be not ingrown anymore, and how do you get it to reattach? Now that's a challenge, because about half of it was detached. So what I did for her is I recommended she have bilateral nail avulsions, and then after 3 months, so doing a staged procedure, and then after 3 months coming back in when there's about 3 millimeters of nail growth, and I'm going to apply Onifix on them. And I've had that work a couple of times. It's not like working 100% of the time, but it's like the best thing I have. I think it works better than just doing the Onifix itself. I think it's better to avulse the nail. I know there are other issues with avulsing the nail, but in these cases with the kind of an ingrown toenail, lifted toenail, and a thickened toenail, I think it's a pretty good option. So unless you have a better option, please let me know. That would help me out. Okay. And then the next patient, this was a patient that had lateral ankle instability. He's about 50 years old, young guy, very active. Had some lateral ankle splains when he was younger, and now he's getting them more as he's getting older. He has a cavus foot type, so I'm going to have him see one of my colleagues for lateral ankle stabilization. I talked to him about orthotics, but he kind of wanted just to fix this thing. Next was a wart follow-up, I guess, that canceled. I'm going to start telling you my cancellations too, because it's good to know. Not everything goes great. There are some cancellations. But this one was double booked, I think. No, actually it wasn't double booked. No. But anyway, it should have been. Next was a 62-year-old. She was here for an MRI follow-up. She had about 5 weeks ago a cortisone injection to her plantar fascia. And then her whole ankle started to swell up, and she was concerned. It swelled up for about 3 weeks. I don't think it was from that. I think she had a swollen ankle, and then she requested from her doctor an MRI. And the MRI showed bone marrow edema within the talar head and also in a portion of the navicular. There's no pain right now. I reviewed the MRI with her. I'm not exactly sure what caused it, but now she's feeling much better. So that was my day with patients. It was kind of a good day. I'm glad we're done with the ModMed training. I think ModMed will be superior. I kind of bashed it in the beginning, but I think it'll be superior in other things. Like, for example, when I do an X-ray read or an MRI read, I think I'll get credit for that now. Or when I read someone else's X-rays, I'll get a credit for that now. I think my billing is going to be better with the level of the visit, because the ModMed is almost like integrated in there. I think all in all, I'm saying this without switching totally, I think it's a better EMR for us as podiatrists to make us have better notes because of this integrated billing aspect. They did say they had a new kind of AI scribe starting, which I'm kind of excited about. I'm kind of worried for Morali, actually, because if it's good, it might be a good option to use, and they could just kind of pull in the different types of templates and things like that. So I also want to give a shout out. I did get a nice one-page report from another doctor. She is in private practice as well, by herself. And I just want to give a shout out to this. So I sent this out. I read it in one of the previous podcasts, my one-page report. So if you have yours, please send it to me, and I'll kind of share it with others. I'm going to take some of the high things I haven't thought about, but I want to bring up what she's kind of working on. So she's working on avoidable write-offs project. I don't even know what avoidable write-offs are, so I feel like in this I feel a little uncertain. So maybe we have to see how many things we write off, but she has a very low write-off thing. A project patient engagement. So she has ModMed as well, and using Clara, so to kind of have a good experience before the appointment. I thought of different ways of doing this, of like sending out patient education information or guiding them to a web page with information, and that's something we have to figure out because within ModMed there is no way to really send patient education information. So I'm thinking I may need a new page on our website. Also, she had a good first quarter. So her first quarter, the per visit collected was 233. The per visit, I think it probably received was 174. So that's good per visit. Worked 200 hours in the last 3 months, which I don't know how much. I don't know how much that is. That's a lot or a little. That's not that many. 70 hours every month, which is. Wow, that's good. I think I'm still kind of learning how to read her report here. The total patients were 1286. The new patients were actually 1155. The new patients were 179. The net charges were 303. 303,000, and the collections were 225, which I think is good. I think she might not work as many hours as me, so I kind of like this. I think she's doing really profitable. And then she has been working on a combination Shockwave with laser. I like that idea, especially if you would have like one of these unassisted lasers. I like that idea. I think the way that Storz does that is they have the EMTT, which is kind of an unassisted device. I think it kind of like you could use it kind of like a laser. And but she's doing that. I'm combining Shockwave with like an amnio or like an orthotic or something else like that. But I like this idea. And then she's kind of what she's working on like going out and remaking, bringing in new patients, and she kind of gets distracted with all the messages. So I that's where I feel I'm good. I don't really check any communications or things like that. Most of the time, my staff do that. And so those were her one page. So if you have your own one page of like kind of what's working, you want to share your things with me, I'll share it with others. I'm not going to share people's names, but I think it's good so we can kind of see what other people are working on for each quarter, each month, whenever you want to send that to me. Okay. Once again, hope you guys enjoyed this one. Have a good one.